thank you very much, and welcome to all of you to the annual NORA Symposium. It's a delight to be able to be here and to see that we have the kind of participation that we do. And I was very interested in the questions, by the way. It's also my pleasure to introduce your keynote today, and that, of course, is Dr. Michael T. Osterholm. And I guess I would say this, that if you don't know who Michael is, then you must have been living under a rock for at least the past year or so. And but just to give you a taste of Michael's background, I will tell you that right off the bat, he is one of the world's leading infectious disease experts, as you know, on a first-name basis with so many of the other experts in the world, including Dr. Tony Fauci and so forth. He also is director of the Center of Infectious Disease Research and Policy, CIDRAP, here at the University of Minnesota. And some of you may know the story that that center was actually founded just one day before 9/11 in 2001. But Michael also is a distinguished teaching professor, as well as being a member of the faculty in the Division of Environmental Health Sciences. He's been an international leader on the scene of infectious disease and preparedness for pandemics for so many years. And prior to that, of course, he was the state epidemiologist. He's the author of a huge number of papers and a very well-known New York Times bestseller book on killer germs. And if you haven't read that book, I think that it would be very much worth your while. That came out in 2017, just prior to the COVID-19. He's also worked for quite a number of presidents, both Republican and Democrat, and he prides himself on being a nonpartisan infectious disease expert. And as you know, it doesn't make any difference who's in political office. They need the advice of one of the world's leading infectious disease experts. And with that, it is my pleasure to introduce Dr. Michael Osterholm.
Well, thank you very much, John. I appreciate the kind introduction, and it's really my privilege to be with you here today to discuss this issue of what I would call the ever-evolving pandemic of COVID-19. I think we're going to start off here with me offering just a few comments about where we're at and what's happening right now. And then I think Jeff and I are going to have the opportunity to have a bit of a discussion with you. I have to say that, first of all, it's an honor to be on this program, but it's also a real honor to work with Jeff. One of the very best things I ever did in all of public health was hire Jeff as a state public health veterinarian at the Minnesota Department of Health a few years ago. I won't even say how long ago, a few years ago. And it has been a great opportunity and honor to work with him over all these years. So where are we at today with the issue of the COVID-19 pandemic? Let me just start out by saying I think these are the best of times and the worst of times, to paraphrase a very famous story. These are the best of times in that if you look at the vaccines that we have today and what's happened with vaccine research and development in such a short period of time has been nothing short of really, truly kind of a modern medical miracle. It combines in the high-income countries what I would call a Manhattan Project with a Marshall Plan to get the vaccines out. I'll come back to that because there still is a great deal of challenge with vaccines here in this country as well as around the world. The second part of what I want to share with you really is the not so good at times, you might say. Right now, today is the darkest day of the pandemic we've had since the beginning. Today we have, as a world, reporting more cases at any time since the pandemic began. Last week, 5.4 million cases reported the WHO for the week, surpassing the previous peak of 5.1 million in January. By the way, a peak that went back down to almost 2 million by February, and people said, haha, it's all done. Today, the single largest number of cases reported from any country in the world were reported by India, with 325 million or 325,000 cases reported in India today. India is literally a country on fire as we know it. In cities like Delhi, 20 million people, there's not a single ICU bed that's open right now in all of Delhi. Major challenges there in terms of cases and deaths. If one looks around the world, it's a challenge because of outbreaks in South America, Brazil, the adjoining countries now. We've seen in Uruguay just in the past 2 weeks, twice they had the highest number of cases per capita in the world. We go to Europe, we still continue to see major activity there, particularly in places like Sweden, a model that had been held out by many as the way to do it. And last summer, they held down the number of cases and deaths, and they had reached herd immunity. Well, today I can tell you that's simply not true. They're in the top 5 countries in the world for per capita cases and have many severe challenges, including an overview that I'd urge you all to read that was published in Lancet just 2 days ago, highly critical of the Swedish government response to COVID. I could go along to a number of countries and point out that this is a pandemic that truly is on fire throughout the world. And let me just back up and give you a sense of what's happening in this country, and then I'll comment on the vaccines and what it means. Number one is that when this first emerged in the United States, back last April, when we saw really the flash of cases, you might say, Boston, particularly New York, the increased activity in Chicago, Detroit, Atlanta, New Orleans, some in Seattle area, Southern California, really wasn't the pattern that eventually became a really critical pattern for us to follow. That was just kind of the opening shot. And then case numbers really came down from the 32,000 a day that were seen in those cities in April to around the time of Memorial Day, when it actually went to 20,000 cases a day. But ironically, most of the cases were concentrated in the upper Midwest, where we actually saw somewhat of a small peak. Those cases subsided for reasons we're not yet completely clear. And then in late June, the southern Sunbelt states lit up from California to Georgia, and we saw those numbers climb to 70,000 cases a day. People could not believe what we were seeing, 1,300 deaths a day. At that point, those cases subsided. They dropped, even though there had been a tremendous impact on some of the southern states. And we got into August down to about 26,000 cases a day, and people began to feel like with this shifting baseline, wasn't this great? We now have really solved the problem. Vaccines were still coming. They weren't here yet, but at least we had hoped they would be coming. And then shortly after that drop occurred, the upper Midwest lit up again. If you look at the rates of new infections in states like North Dakota and South Dakota, there was a period of time where they had the highest rates of new cases anywhere in the world. We saw the Dakotas, Nebraska, Iowa, Minnesota, Wisconsin, Michigan, Illinois, all light up substantially, and it got us to 200,000 cases a day on November 20th. And then case numbers dropped again. And by early December, we were back down to about 160,000 cases a day. And I say down, that surely seems ironic when it just a few months before 70,000 was a house on fire event. And then when those numbers dropped, guess what? The southern Sunbelt states lit up again. And this time, from California to Georgia, we got up to 300,000 cases a day, with cases surely occurring in other states, but really hard hit in the southern Sunbelt states. Then that number dropped precipitously. And we just have to acknowledge, from a public health perspective, surely we can do things and did do things to shave off the size of those peaks. But why the virus suddenly increased in its transmission, why it decreased, we are not sure why. We don't know. We do know that certain public health measures like distancing requirements and so forth can have a big impact when transmission takes off. But for example, last October, I was asked on the Meet the Press program why Florida wasn't seeing cases after they had basically opened up everything there. And I said, just wait, it's just a matter of time. Well, 1st of November came, the 15th of November, the end of November, and of course, everyone reminded me how I'd made that statement. In the first part of December, same thing. And then all of a sudden around December 15th, Florida took off. And by the middle of January, Florida, part of this 300,000 cases a day, had over 1/3 of their ICUs were virtually closed to new admissions because they were so overrun. Why did it take 2.5 to 3 months with no real public health activity to cause that virus to happen again? It's not seasonality. Seasonality would mean that what happened in July and repeated again in January somehow is seasonality. Also, if you look at what's happening in the southern northern hemispheres, there's still no evidence of seasonality. So first of all, we have to acknowledge that these patterns occur and we don't know exactly why. Same thing has been seen with influenza. I just would remind you, while it's a totally different virus, just remember that in 2009, when H1N1 appeared, it started in early March in parts of Mexico. It spread throughout the world quickly, and by mid-April, we were seeing peaks of cases around the world. And then suddenly it just dropped, just disappeared. There were no mitigation strategies put in place. There was no masking, there was no distancing, there was no vaccine. And then it was pretty quiet through most of the summer until middle August, when in the southern states of the United States, it started up again. Hottest days of the summer. And at that point, it took off, and guess what? It peaked out in late September, dropping precipitously in October, well before a vaccine ever arrived. Now, what was driving that pandemic? Why did we see that happen? Why did we see all the other influenza viruses disappear during that time? Why do we see many of the other respiratory pathogens disappear during that time, just like we're seeing now with COVID? We don't know. And I think that COVID is following some of those same Mother Nature-built patterns that we just don't understand. I say all this because let's take a look at the United States right now. We are now part of a new world of COVID-19 called the world of the variants. Prior to November of last year, all these variants, the mutated viruses that we saw out there, were more of an anomaly. They were almost as if somehow we were talking about red cars versus blue cars versus green cars. No one really ascribed any kind of activity to these viruses that would have impact on public health or personal health issues. And then suddenly we realized, wait a minute, we had one virus that emerged in the United Kingdom, B117, that now was a virus that was much more transmissible, and data today confirmed that it's anywhere from 50 to 100% more transmissible than the old wild-type strains, and it also caused more serious illness. In some cases, as high as 50 to 60% were the estimates. Those were two areas of concern now, more transmissibility and more serious illness. And then in addition, we saw other variants develop in Brazil. We saw similar ones in South Africa, where now there was a third bucket of concern about these variants, that they could actually evade the immune protection of either vaccine or natural infection. Now, grant you, we're still learning a lot about those kinds of variants, and it surely doesn't mean that the vaccines can't have impact, but it's still unclear how much impact. Do they just merely cause a reduction in overall protection against clinical disease, but still protect against serious illness and hospitalizations is still not yet clear. But each day now we're seeing more variants emerge. Just today, a new variant has been discussed coming from Texas with a new set of mutation combinations. So we now live in what I call, to paraphrase the old Fifth Dimension song about the dawning of the age of Aquarius, this is now the dawning of the age of the variants. And we don't quite understand what that means, with one exception. We are now confronted with B117 in the United States, the one that we talked about earlier in England. To remind you that England just is opening up right now. They have spent the last 3 months in lockdown. They went from a period where they had, if it were equivalent to the United States, would have been 195,000 hospitalizations a day here. The most we ever got last January was 130,000, and our system was incredibly stressed. So clearly this is a very serious infection, and one that we are seeing now worldwide. Why are we concerned here today? Because even though we have these great vaccines, and they're great. I'll talk more in a moment about the J&J vaccine and the challenges we have with it right now. But in fact, the mRNA vaccines continue to provide very good protection. And the fact of the matter is, we're no longer talking about do the vaccines work, we're talking about whether people take the vaccines. For example, Michigan, a state that now has vaccine levels among some of the highest in the country, are still seeing this very, very serious surge, a surge that is equivalent, if not higher, to what we saw last November in their worst phase. Ironically, today, in 20 different counties in Michigan, up to 60% of people who had scheduled visits to get vaccinated didn't show up. We're seeing people now across the country saying, I don't know if I need this vaccine or not. Well, I can tell you right now that there are at least 20 states in this country that have substantially lower levels of vaccination rates than Michigan, or Minnesota for that matter, which is still unclear just what's going to happen here. We have surely seen the initial part of this surge similar to Michigan. We're hopeful that, in fact, we may be at a period where we're seeing a leveling off of cases. We don't know that yet, but we still have a lot of people who are yet unprotected, either from vaccination or from previously having had infection. So I don't know what the next 2 to 3 months will look like in this country. What if the southern states light up again like they have in the previous patterns? Will we see surges in many of those states? We don't know. Surely it's possible. But I will say right now that getting people vaccinated is a very, very most important and best thing that we can do. Now, one challenge we have right now is with vaccine, almost 90% of the vaccine that has been used to date has gone to just 10 countries. Much of the low and middle income countries of the world have not had access to the vaccine. In addition, they have their own challenges of convincing people to take the vaccine. One source that was considered to be an important source of vaccine for low and middle income countries as part of a program called COVAX with the World Health Organization was the Serum Institute of India. But unfortunately, because of the wide-scale activity there in India, the governments have now prohibited the export of these vaccines outside of India. And so again, the low and middle income countries are largely left without any vaccine. Now, this is clearly a humanitarian issue. There's no question about that. But it's also a strategic issue for protecting our vaccines. The way we're going to see these vaccines compromised going forward is going to be a situation related to how many variants emerge and what kind of variants. And every time there is another infection transmission that occurs somewhere in the world, it's another throw at the genetic relic table for this virus. And so we have every reason to be concerned about this widespread global activity, and if nothing else, out of a very selfish intent to understand that that could very well threaten the security of our vaccines that we have here right now in this country. So we have many questions left. We have lots of people who are tired of this pandemic that want to move on. For that reason, they do not want to have any kind of restrictions on what they do, how they do, or where they do it. They don't want to get vaccinated. It's become a very political issue for many. I understand that, but I will also tell you that we will not achieve a new normal where people can feel safe going into many public spaces if we continue to see the transmission even at a lower level than we have now, but yet sustained. The vaccines are, in fact, great, but a vaccine that's great still means an efficacy for even healthy adults of 90 to 95%. Well, think about that if you're talking about millions of people being potentially exposed to this virus. We have seen breakthroughs that have occurred in the, more than 1,000 in this country, and when we actually could understand exactly how many had happened today, it would be even more than that. But that fits well within the pattern of that 90 to 95% protection. I think we still have challenges in our older population, particularly those 65 and older, 75 and older, whereas we know from influenza vaccine protection that it's not unusual to see a situation where a vaccine that is 50 or 60% efficacious or effective in young adults may approach zero protection in older adults. And so we're worried and concerned about still seeing a number of breakthrough cases, particularly in that older age population. And again, a classic public health challenge. Today, many of the people working in long-term care providing that critical nursing support care are people who are foreign-born, people who have other reasons why they don't want to be vaccinated. And we are now seeing a series of large outbreaks of COVID-19 in workers in long-term care facilities right as I speak. Well, if I'm a long-term care resident and I may be frail elderly, think about the risk now that I have, for me, being in a facility where the workers are getting sick. I'm not spreading it at this point necessarily, but I'm more likely to be the breakthrough case that can occur. The second point that I just want to raise today is B117 has fundamentally changed the epidemiology of this situation from a standpoint of pediatric cases. I was one of those very supportive of bringing kids back to school in class learning for K through 8th grade early on in the pandemic, we saw limited evidence of transmission there. We saw limited evidence of kids playing an important role disseminating the virus in the community. And we basically came to realize that this was not an influenza model. Anybody who understands influenza in the community knows that, in fact, once you see outbreaks in grade schools, it's just a matter of 10 days to 2 weeks before the whole community is saturated. The kids serve as wonderful ways to spread the virus. We didn't see that with COVID-19. That's all changed with B117. We are seeing it extensively now. Transmission to and by kids. Right now, in part due to the vaccination of our older populations at higher levels, we're seeing our ICUs. Many of them are individuals in their 30s, 40s, and 50s, often with an underlying health condition such as their increased body mass index or diabetes or something. But it's a whole new ballgame in the intensive care units today. And this is actual true incidence. This is not proportion, meaning that if you surely cut down the number of older people in ICU care needs, then you would just expect to see more percentage-wise in the younger age populations. No, it's not just that. The incidence is actually up from what we've seen in previous outbreaks. We think that many of the individuals in that age group that are being exposed to younger kids. We are seeing more severe illness in younger kids. So this is a new epidemiology. So I would have to just conclude my comments here by saying that I should have started this presentation with a disclosure. The disclosure is to you that I probably know less about COVID-19 today than I did 6 months ago, and that this is a time for us all to be very humble in the science world dealing with this virus. We have lots left to learn. It's teaching us things every day, and that we have to understand we're not driving this tiger, we're riding it. And how that will play out will be in part how well our vaccines work, who's able to get vaccines, how we deal with the variants, and in fact, what we will do to continue to protect vulnerable populations until we have sufficient number of people protected in our communities. The last piece I would say is we're, of course, going to be learning how long do COVID vaccines last? Does the protection last a year, 2 years? What does it mean? The early data we have says that, in fact, at 6 months, we still have pretty good protection with the mRNA vaccines. Last point, what's happening with the J&J vaccine and the AstraZeneca vaccine? Remember that the Moderna and Pfizer vaccines are both messenger RNA vaccines, whereas the other two use an adenovirus platform for the administration. This is a attenuated cold virus. It's basically doesn't replicate in the human body, but it's able to get the critical material into the cell for that cell then to produce the spike protein, which results in the immune response. At this point, there is surely clear evidence that there is, in fact, an increased occurrence of certain blood clotting events in the brain and in the abdomen with these vaccines. But when one looks from a public health perspective, right now, at least with the early data we have, suggests that risk, particularly if you look at women between the ages of 18 and 48, which have been the primary group impacted, the rate of that is about 0.4 per 100,000 persons vaccinated. If you look at natural disease of COVID-19 having these same conditions, it's about 4 to 20 per 100,000 persons who get COVID-19. Clearly, from the standpoint of almost any other type of medical intervention, we'd say the risk is worth it here because the benefits are substantially more. And yet I worry as the ACIP meets on Friday, and I believe will in fact release the pause on these vaccines as single doses and with much more favorable environmental handling conditions have played a key role in reaching some populations. Will, in fact, this cause more vaccine hesitancy with what we've experienced? It's surely possible. I support the pause, and I have supported it. For nothing else, the public has to understand we take vaccine safety very seriously. Nothing was glossed over here. Everyone will know what we know and what we don't know and be allowed to make their own decisions. I personally would advise any one of my family members, if the vaccine they had before them were the J&J vaccine, get it. And so we'll see what happens on Friday. So with that, all I can say is stay tuned. There's still a lot to go in this show. It is, in fact, I think, one that is far from done. And as I said earlier, I think some days the more I know, the less I know. And that may be reflected in my inept answers to some of your questions. But with that, I'll turn it back over to my dear, dear friend and colleague, Dr. Bender, and go from there. Thanks, Jeff.
Thanks so much, Mike. Really appreciate your comments, your update, really highlighting, again, the global challenge and what we're seeing, the issues of the vulnerable populations, the active discussion on and ever-changing landscape on variants and what we're seeing, and also just the clinical changes that we're seeing as well. And then also just the fact that we've had some success with the vaccines, but we can't put all our eggs in that basket. So I really appreciate your direct comments. I have a number of questions that are starting to come in, and I would encourage folks who've got some questions to please start to put those in the Q&A box. Mike, I'm going to start off with two that have come through so far. One is with a focus on occupations and realizing that occupations is often where disease transmission is occurring. In your experience, what would you say are some key things to guide employers and as well as workers regarding just continuing to think about COVID risks?
Well, let me separate this into two buckets. One was before there was adequate vaccine supplies, and one's after. Also, I do have to acknowledge that the overlay of these vaccines still yet being emergency use authorization vaccines has some impact on what we can and can't do with them. But I think that will change soon as the companies are applying for full licensure, which will then make them a licensed biologic product, and that's a different situation than being a emergency use authorization product only. Before we had sufficient vaccine for everyone that wanted it, public health had to make some really, really tough decisions. And they went back and forth about what those decisions were relative to impact on society. And no one has been satisfied that there was the right answer. One was one that was very much based on age. If you actually look at the data, 80% of the severe illnesses and deaths occurred in those over 65 years of age, up in the previous part of the pandemic. And so when one looked at that, and said, we're going to make these the priority. And when we say priority, we're talking about making sure we get everyone, whether it regard to gender, race, ethnicity, geographic location, whatever. And there was actually some modeling data that supported that the clear racial inequities that are occurring in this disease by all estimates, whether it be the burden of illness, deaths, impact on occupational activities, finances. This has been an absolute horrible, horrible situation relative to that. But even there, the best data we had said you'll still have more public health impact concentrating 65 years of age and older. Now, that was not satisfactory to many who were put into harm's way every day in their jobs, and I get that. It wasn't satisfactory when you realized the socioeconomic status considerations of those who are living in substandard housing relative to space, so that the single mom who has two young kids who lives with a mother who might get infected at work can't go home and quarantine, quote unquote, because there's no place to quarantine in that single or double bedroom apartment. Those are all challenges. Once we begin to move through the 65 years of age and older, people begin to say, well, how do we move this down? Is it better to go with occupational exposures, which we know clearly have been a challenge, and some very dramatic, such as the meatpacking industry, et cetera, where we've seen some real challenges. The healthcare industry, where we've seen in healthcare facilities real challenges. So I think that at this point, and I'm involved continually with the discussions, the Biden-Harris transition team, as you know, appointed a COVID-19 advisory board, which I was on, and we've continued to meet, even though we're not a federally certified advisory committee. And while it's not an official meeting that we have, we do share our information indirectly with the administration. And we've had lots of discussions recently about how could we maximize on reducing both transmission and severe illness in our communities. And I got to tell you, there are a lot of bright people in this group, and we can't come up with one single answer. When you look right now, we believe young kids are really spreading the virus, specifically in our communities. Well, we don't have a licensed vaccine for them, but should we be vaccinating their parents, the people who have most contact with them, like we do teachers, and we have started to vaccinate teachers. So I think at this point, it's fair to say that it has been a hodgepodge, and it's not been a good hodgepodge of who's now getting vaccinated. That is changing, however. And what I mean by changing is I think within the next week to 10 days, you're going to see in many locations in this country ample vaccine supplies where no one should be turned down. Everyone should have access. And the question will be then, well, how do you do outreach, though, to those that can't readily get to the vaccine? People who are in home locations that may be 2 public bus rides away from getting a vaccine, and they have mobility challenges. So I think that this is going to be the next step as to how do we cover the rest of our country, and for that matter, the rest of the world. The one additional challenge I would just add is I think vaccine hesitancy is going to become a major, major challenge. I think there could be as high as a third or more of the population that just refuses to get vaccinated for a variety of different reasons. If that be the case, we will continue to see sustained transmission in our communities. It's just that straightforward and simple. And, vaccines are great. These vaccines, as I pointed out, 90-95% effective in younger, healthy adults. Well, imagine I am in an occupational setting where a fireproof suit seems to serve me very well, but that suit is only 90-95% effective. Would I willingly go walk into a 10-foot wall of flames just because I have my 90-95% protective suit on? No, I wouldn't. I'd still try to avoid them. And I think you're going to find that among the vaccinated populations today, more of us who are vaccinated are going to find ways to get together and be together and do it safely. A party of 8, 4 couples together, all vaccinated, have it. Man, that's great. Go for it. Hug and kiss and sit around the dinner table and laugh. But would I go to a restaurant today for the same situation? No, I wouldn't, because I know that there is still too much transmission in our communities. That why would I want to take my 90-95% protective fire suit and try to walk through the 10-foot wall of flames? So I think we've still got a lot of work to do there to bring down transmission in our communities in such a way that we can then have the discussions about what do we open up and how. Finally, I'd just leave it with the last piece. You saw what happened to the governor in Michigan. You see what's happening with governors around the country. Their legislatures are virtually taking away the powers that they had under Emergency Powers Acts to do things. So when Governor Whitmer in Michigan asked the administration for more vaccine, the answer was no, we need to get it to the other states. But more importantly, it wouldn't have much of an impact for at least 4 to 5 of 6 weeks after it arrived because of that long to basically develop immunity. What you need to do is shut down things. You need to, put into place distancing recommendations that would, in fact, reduce transmission. And she couldn't do it. Mm-hmm. Someone who had been a very strong supporter of many of these actions. And why? Because her legislatures were, both the House and the Senate were ready to take away additional powers from her. And she already had a court decision go against her by filed by leading Republicans in the state. So I think that this is going to continue to also be a challenge is what can we do when we get into these difficult situations with vaccines and the need for continued public health mitigation strategies.
So Mike, along those lines, one of the questions that have come in is regarding, we definitely have a social fatigue issue, and basically, you raised the question about community transmission. And, now we've got, more folks wanting to get on planes and travel. Can you comment on just what this potentially means for us and how do we actually talk about this? Here we've got, a number of airlines are moving from, providing space to not providing, space between folks. Could you comment just on kind of the travel and travel implications?
Well, let me break this one down into 2 categories. What are the facts and what is the reality? Let me just say at the outset, the reality is I'm probably example number 1. Prior to March 10th of last year, I flew about 150,000 air miles a year, as you know. Like you, I did a lot of international work and travel. And I have not been on a plane since March 10th of a year ago. and I don't have an interest in getting in one anytime soon. Instead, I just do 150,000 hours of Zoom every year. And, that's not all totally rational in the sense if you look at one's overall risk of where it's at, if I use appropriate respiratory protection. And I think a lot of people are going to have a challenge finding themselves coming back. I mean, I can give you a more, what I would call less reasonable scenario for avoiding contact, even more so than that. And that is couples who are now vaccinated, who still feel uncomfortable going to someone else's house where they're vaccinated without a mask on. You don't need that. That just is not necessary. And I think you're going to see the guidelines come to reflect that more and more. But I think the challenge we have right now is we do have areas where we're seeing substantial transmission. And so do I want to walk into that wall of fire? And what level does transmission have to be driven down to before people feel comfortable going into a bar where without face cloth coverings on, people will do what they do. And I'm not even suggesting here that face cloth coverings are necessarily as effective as one might need for an evening at a bar. But no matter what, you're going to have it off because you're going to be drinking and you're going to be loud. And, do I want to go into a bar where there may be 2 or 3 or 4 people in there? Do I want to go in there where there may be someone who, under the conditions that they're in there, will result in a super spreading kind of event? Our own health department has done an incredible job documenting how many bars and restaurants have been involved with outbreaks. So when will I feel safe again going back into those? What will it take? And I don't think we understand that yet. I don't think we understand on airplanes yet exactly what that means, because airplanes are not just being on the plane. Airplanes are everything else about travel, getting to the airport, in the lines, going through TSA, collecting your bags, getting a ride somewhere. So I think these are all huge challenges yet that, we really haven't worked out. And CDC needs to spend more time. Right now, I know they're bogged down on the outdoor air recommendations. I personally would just say right now, I have no challenge at all without any kind of face cloth covering with my vaccination, being out there, walking around a park, and obviously not stopping and talking to anyone, but walking by people. I'm perfectly fine with that based on everything I know about what we have for infectious dose and concentration in the air of the virus.
So, Mike, we've got a lot of questions, and I really apologize, folks. I don't think I'll be able to get to all of them. One of the questions, Mike, that we've got is regarding concern about, the long-term care facilities and increased incidence in healthcare workers and the issue of mandatory vaccination. Is that something that we need to look to for healthcare providers as some sort of mandatory vaccination?
I am perfectly comfortable with that. Once a vaccine becomes a licensed vaccine, no longer an emergency use authorization, unless someone has a legitimate medical contraindication, I think that we should, because we are putting people in harm's way. And, what right do we have to do that? And again, it's not that anyone intentionally wants to transmit the virus, but the bottom line is when you're asymptomatic, you have no idea you may be infectious, you're transmitting lots of virus. And so I think that I'm perfectly comfortable looking at the benefits and the risks of doing such a thing. And I think that you're going to find as a society, this is going to become more and more of an issue. Now, when I say more and more of an issue, I think more people will support it over time, but there's going to be a very hardcore, smaller group of people that won't. This is going to get us into this concept of immune passports. I just this morning was on a call with a very, very major concert venue in this country. And they're struggling as to how and when to get back open again and how they're going to do that. And they're finding from their members, they want everyone to be vaccinated, and they want proof of that vaccination before they'll be allowed back into that venue as either a performer, a staff member, or the audience. Now, will that happen? Will people be able to do that? Well, you can have a choice of not going to the concert. You can have a choice not working there. The question will be, what will people decide to do with that? And at the same time, would you want to sit next to somebody that halfway through the performance starts to cough a bit and you don't know who they are and you don't know what it's all about? Wouldn't that be a great evening celebration to be out doing that? So I think we're going to have to find these norms somewhere. They're going to allow us to, not violate individual freedoms or rights in the way that all of us would agree are inappropriate. But at the same time, you don't have the right to be in public transmitting a virus to someone if there are ways to stop that. And I think that that's where we're going to have those discussions about mandatory vaccinations.
So another question, Mike, is regarding a family farm that hosts classes and public tour events, and they say they've been closed since March of 2019. They've got their vaccines, and they're in a community that is an anti-vaccination community and a very loud rural community, and but they're wanting to follow public policies, and social distancing are really difficult to or impossible to enforce. How would you guide them in their thinking, in regarding their business and operations?
Well, this is not new to an organization like this, as you have investigated numerous epidemics of foodborne disease pathogens that have occurred in similar settings. And the challenge is always, what do you do about that and how do you deal with it? The difference is, if you're talking about E. coli or Campylobacter, you don't have a vaccine like we do for this. I think the challenge we're going to have is right now, for example, young kids are viral reactors. I mean, they are transmitting substantially in our communities. It's a real challenge. So just having kids together by itself is a challenge. And I think many of the schools are understanding that, particularly as they find reestablishing in-class learning has almost been impossible in many schools because of issues around quarantine and kids getting sent home after just one case shows up in the school, often multiple cases. I think you're playing with fire if you basically have activities like this where unvaccinated people or people who have not been previously infected who have antibody are coming together. You can say, well, how do I monitor that? How do I know that? That's a challenge. I don't disagree. But I think that you're going to find that we're going to see more and more events like this where we do see transmission when there is a substantial number of people unvaccinated in this community anti-vaccine. And I think that you have to ask yourself, is that a risk I want to take? Is that something, if I'm responsible for an event and grandma gets infected and dies, is that something I'm okay with? Can I accept that, this event is what led to that? And I think this is going to be something we're going to be challenged with again. What do you require for vaccination status? What do you require for antibody status? This goes back to that point of immune passports I talked about. This is not a satisfactory answer I'm giving you. It's an answer that says this is reality, and there isn't a norm yet. There isn't a place that says this is exactly what you have to do. But I think that you're going to find many of these venues, until there's an adequate number of people protected in our society, you're going to have a real challenge with this.
So, Mike, I know our time is winding up, but that is one of the questions that is coming through. What's your opinion about vaccine passports to use in their workplace and social situations, like concerts, and if required, the individual is concerned about fraudulent vaccine cards?
Yep. Well, first of all, I wanted to say I agree completely about the fraudulent record issue. This is going to be the challenge. How we do this, I don't know, but it's going to happen. It's not a matter of if. The Biden administration has indicated they're not going to lead the way, but they will help provide oversight to planning and process. There are a number of private companies that are already on the issue already. They're dealing with it. There are some places like in New York with the Empire program, et cetera, where they're actually showing, the use of these passports, electronic passports. For many of us on this program today, we gave away our eyeballs and our fingerprints to a private company just so we could get in and off airplanes quicker. We've already done that. Now we're just merely talking about a health piece that says, was I vaccinated, or do I have antibody, and how do I verify that from a medical standpoint? And so I think you're going to see it happen. I think that already there are places that are starting to capitalize on it, where I think the fraudulent record issue is really important. But I know of restaurants that are starting up in various parts of the country that will only take people who have evidence of vaccination or previous infection with antibody protection. And that includes not just patrons, but also all the staff, all their vendors, and the management. And so I think that that's going to start happening, because that's where people want to go then. They say, yeah, I'll go out to dinner tonight, but I want to go to this place. And I think it's like the old days of smoking. Remember when some bars went non-smoking, some didn't yet? People made choices. And I think you're going to see the same thing here. Eventually, I think passports will become more of the norm.
So, Mike, I recognize that it's 1:45 and you've got a limited time here with us. I think the last parting thought that I'd ask is that you often talk about which inning are we in, and you mentioned that. So, what inning are we in, or did we start a new game?
We're in about 4 minutes into the first quarter. I think when the variants arrived in November, I stopped using a baseball analogy because this isn't a whole new ball game. And I think that they are surely providing us with challenges we hadn't anticipated. And that's going to be a huge issue. So I don't know where we're at, but I know we got a long ways to go yet.
Well, I really appreciate this. I know that you've got a very tight schedule, and I'm going to be respectful of your time here that you need to just escape. So,
well, thanks for having me. And again, Dean Finnegan, thank you for that kind introduction, and I appreciate it. So, thank you.
Great. Thanks, Mike.